Welcome to the Journal of Biophilic Design podcast. Many thanks for joining us on the Journal of Biophilic Design today. Emergency departments are some of the most intense and emotionally demanding environments in healthcare. In today's episode, we're exploring new research that asks a deceptively simple question. Can just 1 minute of viewing biophilic art meaningfully improve the well-being of clinicians working on the front line? We'll unpack findings from a pilot study which was published in the Journal of Biophilic Design, issue 18, Interior Design. The pilot study that shows measurable reductions in anxiety, fatigue, and negative mood swings among emergency clinicians after a brief exposure to nature-inspired art, highlighting how even small design interventions can have a real impact in high acuity settings. Joining me are two physicians who sit at the intersection of clinical excellence, research, and human experience. Dr Anant Shukla, an emergency physician and sports medicine specialist whose work bridges medicine, humanities, and orthopedics, is a major also in the United States Army and assistant professor at the Uniformed Services University of Health Sciences. Dr Shukla has led multiple grant-funded research projects focused on improving care and clinician experience. We're also joined by Dr Harman Gill, dual-trained in emergency medicine and critical care, with academic interests spanning respiratory failure, cardiac arrest, and procedural education, particularly where care transitions matter most. He brings both scientific rigor and lived insight into the realities of emergency medicine. And together today, we're going to be discussing what this research that they've conducted means for clinician wellbeing, emergency department design, and how biophilic principles could play a role in addressing burnout in healthcare. So first of all, many thanks, if Harman and Anant, for joining us today.
Thank
Thank
you,
you so much,
Dr.
Dr.
Champion.
Champion.
Lovely.
Thank
Well, I wonder if you could start by telling us just a little bit about yourselves, please, a bit about the work you do.
My name is Anant Shukla. I'm a board-certified ER physician here in Colorado Springs with a fellowship training in sports medicine. I'm also kind of one of the physicians for one of the Armored Combat Brigade teams here in the Colorado Springs. And I'm also one of the physicians for the Army World Class Athlete Program, and covering in particular boxing, the marathon team, and wrestling. I'm very passionate about kind of like, the clinician experience. And, I worked very closely with my mentor, kind of the director of research at Dartmouth, when I was a resident there, to develop this project. And we're excited to talk to you about it.
Thank you. Thanks, Anant. And Harman, if you could tell us about yourself, please.
First of all, good morning to those here and good afternoon to those across the ways. And just thank you to the journal, the platform, and to you, Dr. Champion, or should I say Ness. So I'm Harman Gill. I am currently the Director of Education and Academic Development at the NYU Grossman Long Island School of Medicine. Of course, I am EM trained. As you said earlier, I did my EM training at Yale and critical care medicine fellowship at the Cleveland Clinic. And this project, this meeting of the minds with the good Dr. Shukla here, who back in the day was a resident of mine. It seems so long ago, but it's yet how time flies. But as he was saying, as the director of resident research there, one day he came up to me with this fantastic idea that he gives me some credit for, but really it was all him. It was really all him. He had an idea, a plan, a design, and had gone from almost step A to step X. And so while I can sit here and say I'm his co-author, mentor, it really was a lot of work driven by him, done by him, and finessed a little bit by us and the entire team that worked on this project. But personally, I find my career both clinically and non-clinically at the junction of emergency medicine and critical care medicine, and what I actually call acute care medicine. And whether that's care transitions, understanding a problem before you fix the problem, asking a lot of pragmatic, everyday, solvable practical, applicable questions is really what I've dedicated a decade or so of my clinical career to. And along the way, I've met brilliant minds, and I'm so lucky and honored to say that I can learn with them and from them.
I can imagine that both your roles are very stressful. We sometimes we think, normal people, if you want normal people, we have jobs and we get stressed, but I think the pressure that the healthcare workers at all levels are under is extreme. One thing that, the reason I set the journal up was because I witnessed firsthand a view of nature had on my mother's healthcare outcome, and I set the whole journal up. I was an academic originally, and had gone into editorial, and I set the journal up because I wanted to share this research that just a view of nature had on my mum's healthcare outcome, because I was losing her. And she looked at a picture of nature, and basically she started responding to medicine. Her blood pressure came down, and she ended up walking out of there. And it was just from that
Wow.
compelled me to things. So when you sent me, Dr. Shukla, when you sent me your research, it really struck a chord with me, and I'm very keen to support you in this research, and also any future research that you might do in sharing the word. Before we go on to the research, I did want to just ask you a little bit about what a sort of typical day would look like to you both professionally, but just to give us an idea. Thank you.
Yeah, I bet our environments look very, very different. So, Dr. Shukla, you first.
Absolutely. So, I mean, I think, emergency rooms everywhere in the country have a high degree of stress. And it's the degree of support, it's the degree of systems that kind of allow you to mitigate that type of stress. I can tell you that, like, I'll go to an ER shift, and I have kind of a community ER practice right now where individual walk in with some abdominal pain, and they think it might be kind of just gastroenteritis. They might think that it's kind of like, gastritis, and they'll end up getting a CT scan that shows that they have a cancerous mass. And you are kind of like at the intersection. You're like the front line for patients who are coming in who have a problem. There's something going on. They feel like something is wrong with them. And they're coming into an environment that is at times very foreign and very sterile. And the system and our healthcare system, especially here in the United States, can feel very, at times, unempathetic.
Mm.
And especially for the clinicians who, in an ER, whether you're in a big academic center like Dartmouth, Vanderbilt, or at NYU, or in a community place, you're seeing multiple people at the same time. An ER physician is bouncing between multiple rooms. And so imagine I see somebody who came in with some abdominal pain that just didn't feel right, and I have to tell them that they likely have cancer. Going to somebody who, came in with a cough and has a peritonsillar abscess. Going into another room with someone who's having a heart attack. And, switching between those, and then going into another room where it's just a child that, has a little bit of a fever. These are kind of like the type of, mind swings that good emergency clinicians can do, but we are, after all, human. It certainly does take a toll for us. So it can be chaotic, it can be emotionally draining, it can be mentally draining. And that's why our field in particular, and we mentioned this kind of in our research, emergency medicine in particular has higher burnout rates than other specialties, because you really are kind of in this chaos, trying to decipher a plan for someone in need. So happy to hear what Dr. Gill has to say too.
Yeah. First, I'll say I agree with everything that he's just said. And I'll qualify my answer by saying today I'm only going to talk about my emergency medicine practice, and not so much the critical care medicine practice. But I will say that the thematic conclusions that we've drawn in our study about emergency departments and emergency medicine, I would wager our next study would show, would be just as applicable in critical care medicine. And to I've told Anat this and many of my other friends and mentees before. Uh, the best answer I can give you is via example, right? So I'll just recant my thoughts to my last shift. My shift started with a woman wailing through the front door of the emergency department, and she was in labor, active labor. And I can tell you there are probably a lot of places you want to deliver your child, The chaotic emergency department in the middle of winter flu season is not it,
No.
right? And you think about the stress that that mother is going through, the absolute lack of privacy, meeting humans that are not your obstetricians, right? They've never met me, I've never met them, and here we go. You know, you're having a particularly stressful and potentially the best moment of your life. And to fast forward, uh, the lady gave birth to a beautiful baby girl. It was an amazing moment for the mother. It was an amazing moment for me because I have a baby girl. Um, and then, as they say, Murphy's Law, in about 40 minutes, the woman then progressed to have catastrophic postpartum hemorrhage, and we nearly lost her.
Oh no.
And it is the emergency department team that, then has to not just move from that literally 30 minutes ago, moment of elation, moment of team cheer, to like switch gears, go into operation mode where, you're on one hand handling a very acute, sick, real resuscitation um, in the form of the mother, to then also making sure that the care transition for the neonate that has just entered the world is given off to the appropriate neonatal team, that you're marshaling the resources of your nurses, your respiratory therapists, your ancillary staff, your juniors that are on your team who are also going through like, oh my God, how did this go from this to that? And how do we recalibrate and readjust to go from the relatively calm and peaceful and appropriate and happy moment, which, by the way, we don't have a lot of those in the emergency department by definition of it, to here we go, chaos, but controlled chaos, systematic controlled chaos again. And Dr. Shukla probably experienced and is professionally trained in all of this from his army side of things. But us civilians, as he would call it, right, are not rigorously trained. You don't explicitly get that training in medical school. You learn that kind of on the apprenticeship of residency and fellowship. But if you take that aside, just that scenario aside, right, that was about 2 hours of my 9 to 10 hour shift. By the way, there were also 20 other patients. Right? Because I won't tell you the outcome of what happened to the mother. No, they were all fine. But thankfully they were all fine. But what you feel after that is germane to our discussion today, is that you feel a little bit of, in my mind, appropriate stress, appropriate fear, appropriate anxiety, some calm upon success, but that could just as well have not gone as swimmingly as it did in this particular scenario. But the question that has always irked me from a humanitarian perspective is, when I'm going to see the next person, whether they are having a stroke, a heart attack, or just there with the sniffles, right? They don't, for lack of a better word, care what happened to me 20 minutes ago. They expect standard of care. And standard of care is a competent clinician who walks in and does the same thing every time, all the time, regardless of time of day, regardless of what has happened 20 minutes ago. And that's what I would want. That's what I'm sure both of you would want in a clinician when you see them in the emergency department or in the hospital for general. And that's where, we usually just come to our cave-like setting that we describe in this paper, which is really nothing more than, an office space that is not as luxurious as my background. And we take and go again and go again. Just like, when Dr. Shukla has probably seen comrades not have such happy ends or get hurt and whatnot, and still the mission continues, right? And that is our clinical mission, that is our humanitarian mission, but the humanitarian mission is on frequent account in the emergency department, at least overlooked and somewhat given not as much credit as the clinical mission.
Yeah, absolutely. And I think really, really, really valuable to have your both of your perspectives on this and to hear from the workers, as it were, because we are in biophilic design, we often hear about people, the patient journey, the user journey, but the patient side of things, the family side of things, but it's so valuable also to understand it from the healthcare workers, from you guys who are on the front line. And like you say, you're having to be the perfect version of yourself every time you see someone new, and then go back to that, because you've got to engender confidence and everything else. But like you say, you are human and you do have the normal stresses and strains, because you're going to have stresses and strains from your family or from your work, from your everyday life as well, that you're bringing to work, which we talk about. So I wonder if we could move on to the study now, if that's okay, and just
Yeah,
talk
sure.
about what the research was, please.
I'll talk a little bit about this, but actually, Harman helped so much in kind of, refining to make this into a stronger kind of research design. And I did want to say, Ness, like, one thing about, just the inspiration for this study. It came from, during COVID in 2021, 2022, I was a resident, at Dartmouth, and we were having extremely high levels of cases coming in.
Yeah.
And I knew that we had really nice art galleries up in the patient floors. And I started to look into just why wasn't the same type of impact or kind of, product applied to clinicians. And I started to research on this. And in my background, I looked to see that in certain floors, neurosurgery patients where they could look outside or they had biophilic art available to them, those patients actually used less narcotic pain medication than those who didn't. And so I started to see, I was like, we do all this stuff for patients and we do this for even like the visitors of the hospital, but we don't really do this in the emergency department. And so I came up with this idea of, if we do kind of like a simple, almost like a pre-post design type study, where if you can interact with a piece of biophilic art, even for just 1 minute, what would that do to you? Because I have evidence from patient floors, from research, from a lot of the research actually came from Scotland about like the impact of biophilic art on people and their emotional well-being and their emotional state. And in tried designing the study, we went to our art and humanities director, who she chose the artwork. Most of it was kind of derived from the Northeast,
Mhm.
with kind of an idea of just like, this is not something foreign. Like, this is
Yeah.
something like you can go outside and you can look at this. Like, this exists it's not some fantasy. Like, this exists outside. And basically, there's a validated survey. It's called the Daniels five-factor measure of effective well-being. And it was developed kind of at Harvard. And it's a validated survey that we chose because it's simple, because the ER, kind of what we described to you, is chaotic. There's
Yeah.
a lot going on. And if I want to do a measure, it needs to be quick, it needs to be efficient in order for me to kind of get the answers I need. And this is like a 6 question type, survey. Obviously, we added a little bit more kind of demographic stuff, but basically the idea would be, in this cave, in this chaotic area where everyone kind of works, we're going to take one wall and we're going to put one of these biophilic pieces of art that rotates out on a quarterly basis. And any clinician can go in, just scan into the QR code, fill out kind of what is their state of well-being right now, like right now. Like, how do you feel right now? And then after they complete that, they get a timer on their phone, and it says, look at the piece of art for 1 minute. And so the timer goes for 1 minute, and they just engage with the art for 1 minute. And following that, they get a notification and they fill out the survey again. And so it was a very simple kind of pre-post design to see kind of like before and after, what is your state of effective well-being, with just 1 minute. So I love to see Dr. Gill. I hope I explained that. I know I worked very hard with him to design that, but hopefully I didn't miss anything.
No, 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 no. As always, I found myself a little bit of a broken record right now, but I agree with everything that he said. But I want to take a step back and just speak to something that you were saying, Ness, about the timing of the study, right? We were just coming out of the pandemic.
Mm.
right? And there's a lot of in the research world, at least in academic, medical, scientific world, there's a lot of credit that is given to, wow, you did research while you were in COVID.
Mm.
And I would not say that this was definitely in COVID. This was right after. But in New England, where we were in our microenvironment, um, we were a little phase shifted in the sense that everything kind of, takes a little bit longer to get up north, I guess. And then this was, while this was not in the peak of COVID, this was right after. And so again, credit is due where credit is deserved for Anand to like even, I'm sure as a resident in training himself to be able to just think of this idea. And again, then get so much of what he's just said about the research design, the research question, the surveys, and looking that up, and its impact to patient care and narcotic need. It was such a already refined idea that he did right after COVID in the peak of his residency rigors. So kudos. What I will add to the study design is that it's also one of these questions. The first time you hear it as a pure researcher, you're like, hmm, obviously we should study this, but how do you study this, right? Because it's a relatively subjective concept of do you feel better,
Mhm.
right? But to objectively define it and carve that into the rigors of a statistical t-test, which is something that we did to compare means pre and post, is kind of really, was the biggest challenge. One of the other things was, Dartmouth, where the study occurred in the emergency department, right? We are a level one trauma center, which in America, that is the highest designation of a trauma center. And we have all the academic adult pediatric services that you would want in an emergency department. Yet the vast majority of our patient volume, comes also from outside the hospital and other sister hospitals that feed into it in terms of transfers. So our patient volume was around, and correct me if I'm wrong, around 30 to 40,000 a year, which isn't, comparatively speaking, for level one trauma centers, it's not the highest, it's not the lowest, it's, not as somewhere in the middle. And then on top of it, as a result of that, our N or our survey participants, our study participants, this was not a large academic emergency department. This was, a department that at the time, correct me if I'm wrong, had somewhere between 25 to 35 attending faculties, which are considered, as they would say in the UK, consultants,
Mhm.
really fully trained independent practitioners. And we wanted to include everyone. So the study was a pre-post, like you said, used the DFAW tool for statistical analysis, included the t-test to compare means pre and post. And we made it open to any and everyone that would encounter stressful scenarios in the emergency department. And so we included attendings, we included nursing staff, we included advanced practice providers, residents in training, and even folks visiting the emergency department in terms of our off-service resident physicians.
Mhm.
You know about the primary outcomes, and we looked at a pre and a post. But the other thing that was really neat in this is that when the uh, participant in the study took the actual time to look at it, obviously there was a QR code that they'd activate from the phone, but it allowed them to generate and force them, in fact, to generate a unique ID. It could be anything they want. And that allowed us to track the individual components, right? Like if I took the study today and had a pre, how do you correlate it to the post? And we brought that up because we wanted the study participants to feel anonymous, that they could just freely participate and
Mm.
not be judged by these relatively subjective things. But also, if someone wanted to take the study more than once, because you could have a relatively easy day in the emergency department, and you've just come off a vacation, and your incoming subject affect may be a little different than when you've done 4 night shifts in a row, and the pregnant lady just had a bad outcome.
Yeah.
But interestingly, in this study, and we'll talk a little bit about this in the results section, there's not a lot of people who kind of abused the study and artificially skewed results one way or the other. We were able to reach a good N, given the size of our department and the flow of our department. But there were only, correct me if I'm wrong, Anna, only 3 people who took it more than once. And I think that's further not planned exactly, but further credit to the quality and the rigor of the study.
Yeah, thank you. Can you tell us a little bit about what you showed people? Because we're going to talk about the results very shortly, but you showed people different images, didn't you, of nature? Was it 4 images, and it looked like they were seasonal slightly? Is that what
Yes.
Can you tell us what they were and why you chose them, please?
Sure. So we did, just to ensure that there was no bias. So we spoke to our art and humanities director. And so
Mhm.
I went to her and I said, I want you to provide a biophilic piece of art because art is very subjective. What looks good to me, what looks good to Harman, what looks good to you. These are 3 potentially different objects. And what we want to do is just bring biophilia, like nothing with like a personal, swirl on things to the clinician. And so basically, there were 4 separate pieces from a New Hampshire-based photographer that, there was the actual, pieces of art. I don't know if I can share it here on the screen, but I don't think I will be able to do that. But basically, there was a picture that showed kind of like a stream of water, a stream kind of going down, some mountains. There was a view of, October foliage, in the mountains in New Hampshire. There was a picture of 3 birch trees, in kind of the winter, and then another one just of like a calm type of pond. And so they rotated, between 3 to 4 months. Basically, I got a grant from the Jack and Dorothy Byrne Foundation, for which I'm forever thankful that they funded this. And basically,
Yes.
through that, we were able to do the study, and get the support, for the layout, within the cave, which is where we all work, but also to kind of get this art sent over to us and working our partnerships with local artists. So hopefully that answers your question, Ness. Like it really, I did not want, and in terms of research design, there's a lot of bias that comes in with artwork. And so I really wanted to try to protect kind of like, this isn't just what I like. This isn't just what Dr. Gill likes.
Yeah.
This is something that comes from a local artist that we're supporting, and something that everyone can potentially connect with, because it's not I didn't want it to be like this is a picture of Switzerland. This is something realistic. This is
Yeah.
something that you can go outside, and Dartmouth is located in the beautiful upper valley of New Hampshire. You can go outside and see these things, and so I wanted to at least build that. So hopefully that answers your question.
Yeah, absolutely. And I think having localized art is a really important thing as well.
Yeah.
And what I'll do is I'll put the images on the spiel that goes with the podcast, which if people are listening, they can search for it. Obviously, they can can go and have a look at the Journal of Biophilic
Yeah.
Design, issue 18, at the interior design issue, and the whole pilot study has been published there. But also I'll put it on the podcast page. So people go to the journalofbiophilicdesign.com, look at the top podcast tab and be able to search for this podcast, and they'll be able to find the images. I was going to ask you, what, in your opinion, this is obviously a gut feeling, and I think that's, same with me when I put images of nature in, it's because it was such a bland room that, and like you
Yeah.
saw upstairs, it just feels natural, doesn't it? In our homes, we have images around us and photos and everything too, because it brings us comfort. So why, in your perspective, do you think that such a brief intervention can have such a powerful impact on high stress environments like an emergency department?
Yeah, I think that's a really great question, Ness. I mean, I think, and that's why this is such a great area of research, just to figure out like, hey, is there specific aspects of biophilic art that can do this? But I think there's really 3 components that we kind of get. Like the emergency room is, especially where we all work, is a very temporary, chaotic type of inefficient type of workspace at times because we're all kind of coming in, doing our shift and leaving. There's no permanence to it. But the great thing about, having a minute to just focus on a piece of art, well, that's almost like a positive distraction.
Yeah.
Like you are mentally separating yourself from kind of your chaos and going into something that has some stability. You're looking at a mountain, you're looking at some trees, you're looking at a stream, you're looking at water. And it by there's that positive distraction. So you are disengaged for a minute from kind of your at times negative circumstances. The second thing is that there's a little bit of mindfulness that kind of comes into play.
Mm.
You're looking at, something that has some stability, something that has some beauty, something that, is natural, which in an unnatural environment like a level one trauma center where you have tubes and lines and everything like that, it really puts into perspective maybe what you're doing. There's a little bit of mindfulness and self-reflectiveness. And that kind of goes into like what I think might be the third thing, which is kind of you're getting a little bit of reprieve from the clinical chaos. Like if you're seeing and you're focusing and you're looking at this water that's coming down of this of a stream that potentially could be just 3 miles away from this hospital, you realize that, maybe the world is not all negative. Maybe there is something beautiful that you can go back to. And I think those are three main things that I would hypothesize based off of our findings
Mm.
and just having kind of worked on this project with Dr. Gill and our team for many years as what I think there's been such a positive effect. But I'm interested to hear what Dr. Gill has to say.
Yeah, I want to say that going back a little bit to your prior question as well, I also want to reiterate once again the support not just from the Dorothy Byrne Foundation to philanthropically support us, but also our entire team and our department chair at the time, well, currently still Scott Brody to really get this to happen. But to answer the particular question that you've just asked, why does it matter so much? You know, again, I agree with everything that Anant has said, um, but it's also something that I've never really understood about emergency departments is all emergency departments are windowless.
Mm.
I don't know how it is in the UK,
Same, same. It's
but
the same.
but they're always in the basement. They're always in some dungeons, and if I just juxtapose my clinical practice in emergency medicine and critical care medicine, when you go to the intensive care units, a classic patient interaction is you walk into a room and a room usually has a window, and there's something to be said about Mr. Johnson, good morning. And you open the curtain and you see the lights, and there's a circadian day and light rhythm thing that has an impact and influence on patients. Now, granted, those patients are there for longer, and emergency department patients are hopefully not there for days and days and days, although boarding is a real issue
That happens.
these days.
Yeah.
But I more than just the patients, just that this notion of seeing and even getting a glimpse of your outside world,
Yeah.
right, to the clinicians is really important now, because if you imagine, so at the time, actually, this was my reality. I was what's called a nocturnist, right?
Mm.
Meaning I would only do night shifts. And in the peaks of winter, when I'd come to work, it'd be dark. When I'd leave work at 6 a.m., it was still dark. When I'd come back to work next, it was still dark.
Mm.
And I would have no contact in reality in a string of shifts to the outside world. And how do you objectively qualify that impact of my own affect on what I do and how I interact with not just patients, but even my team?
Mm.
Is very difficult, and that's what I think is unique and cool about this study as well. Because while we may not know which one of those three variables that Anand just mentioned in terms of cause and effect and proportional effect,
Yeah.
we know that there is an effect. Clear. There's no denying it. And for I think one of the first times this shows objectively in the emergency department domain that this matters.
Yeah.
And that's why I think we needed to start somewhere. We were okay starting, in with a smaller end, but I think it's important. And to ask what exactly changed, I would say it's a little bit of all of what Anand has said, but
Yeah.
to say and quantify 20%, 30%, 40% cause and effect would be a little challenging.
Maybe we could, I'm going to come back to sort of to have your opinion on how emergency departments should be designed, in your
Mhm.
opinion, as a result of this. But maybe we could just talk a little bit about just drill down a little bit more in the results that you
Mhm.
found, just to kind of give
Mhm.
people a kind of top view of what the outcomes were, please.
Would you like me to do that, Anand, or?
Yeah, go ahead, Dr. Gill.
Yeah, no, they were quite simple. Like the survey mentioned, there were distinct categories of
Mm,
what we called positive feelings and negative feelings. Some simple examples appropriately are, calm, anxiety, nervousness, fatigue, and essentially to sum it all up, we not just from the pre and the post, we found the negative emotions and feelings decrease and the positive ones increase. But what I think is even more phenomenal than that, because again, this would make sense, right? You're not showing them a negative thing. You should have,
yeah.
that should go in the right direction. But what was phenomenal is that these were statistically significant.
Mm,
And that has even
Exactly.
more
Yeah.
meaning to me in that uh, this was a very small study, right? You can imagine if we did the study and we found some signals and correlations, but no statistical significance, then we'd be a little more confused and a little more perplexed as to what to do next. But I was very surprised and very happy to see that despite that entity that I was mentioning earlier, that it wasn't like the same three people taking it over and over and over and again, right? It wasn't skewed by bias in that way, but there was a clear positive signal in the positive aspects and a corrective signal in the relatively negative feelings. We're very satisfied and happy about that. And that's what I think we're able to report. Anand?
Yeah. Yeah, just to piggyback off of that. So we just all the positive emotions, we saw like essentially a statistically significant increase. Like we saw a statistically significant increase in the amount of calm, that people felt before and after the survey. We found a statistically significant feeling of ease, being and feeling kind of, at ease, after completing it. But then also we found statistically significant decreases in negative emotions. So feeling less anxious, feeling less tired, feeling less gloomy, feeling less annoyed. And just to Dr. Gill's point about kind of it's tough to do a study in the emergency room because you're always running around and it's very chaotic. And so what we found is that, a lot of people completed the study when they felt they had time.
Yeah.
But in truth is that we probably had more people look at the study walking through the room when they didn't have time, but they needed to take that 1 minute to take a look at that piece of art.
Hmm.
And so like there's no question in my mind, just anecdotally, having run this study for, a few years, it took us, quite a bit of time to kind of get it off but while we had the art there, many people participated, but not everyone was able to kind of actually, do the survey and everything. Because in an ER, if you have a code, you have a hemorrhage, you have all this stuff going on, you
Mm,
just don't have the mental bandwidth to actually scan in and participate, but you can look at the art.
yeah.
And,
Yes.
and so there's no question that, while we do have a small N, it's just because it's tough to conduct research in a very busy level one trauma center that's essentially the main referral center for the Northeast, or New Hampshire, Vermont, and but yeah, those are kind of the main outcomes that we found,
Yeah.
for our study.
Yeah. Could you give us a couple of numbers just so people can who are listening, you're saying sort of significant statistical increase. Could you give us a couple of so people can, sort of kind of
Sure.
key takeaways?
Absolutely. So, I mean, so in terms of individuals, this is looking at kind of the score level, before and after. So people who did the survey, before looking at it, they had a score of 2.6 in terms of feeling anxious. And following that, it went down to 2, which has a p-value of 0.003. So extremely significant. And then individuals who had a score of feeling 3.6 in terms of calm, following looking at it, it went up to 4.3. That had a p-value of 0.02. And feeling at ease, people who initially looked at before starting had a value of 3.3, and that went up to 4.0. That was also statistically significant with a p-value of 0.003. And I can kind of go through like, the other, p-values. I don't want to,
Yeah, so what
reading
does
the
the
table in
p-value
itself, I
mean?
think.
Sorry, for people who are listening,
Good.
what does that mean in real life? Sorry.
Good question. Yeah.
Yeah.
And so, Dr. Gill, Director of Research, go ahead.
Oh my God. Oh my God. Did you see the genuflection? It's like, oh, okay, here we go. He can talk about the nerdy things and the boring things.
No, no.
No, 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 no. So a p-value is basically a measure that says that the finding that you found was not through pure chance.
Okay.
Right. So when he says a p-value of 0.003, right, in the general medical scientific research world, a p-value of 0.05 is considered kind of the industry standard. And what that means is 0.05 means that if you turn it into a percent, that's 5%.
Okay.
And so you would say that the chances of your finding being due to pure chance is less than 5%. Now, obviously, if you ratchet that down to 0.01, your result becomes even more significant. That your findings that they're just, for lack of a better word, dumb luck, and you just happen to, there's no clear correlation or causation, that thereby pure chance is, that threshold or lower, right? So when he talks about the survey item of anxiety, let's put that in perspective, right? So the of the participants that took the study, they had a score of 2.6 in the anxiety bucket, or in that subcategory, and their post test was 2.0, right? So that there's clearly a numerical difference, right? You go from 2.6 to 2, and anxiety being a relatively negative feeling, right? That improves. So there's a decrease in that
Yeah.
feeling. But the question becomes, is that difference? It sounds very trivial. 0.6. What does that mean, right? And this is where that correlation of a subjective thing to objective and objective back to subjective is that closing that circle of logic is very, very important. So when you say there's a p-value of 0.003, right, that says that there's essentially a 0.3% chance that this result is by pure chance and pure statistical, dumb luck. And so our threshold of statistical significance was 0.05. So this met our statistical significance. So we derived the conclusion from this saying that anxiety decreased,
Mhm.
and it decreased in a statistically significant fashion when it came to that domain. Because it was below our threshold. And we, within that 0.3%, there may be some chance, but that chance is very, very low, and that this is a very meaningful result in the right direction. And to just give a corollary of a positive domain, right? The gloomy signal, right, also went from 2.3 to 1.8, and that was statistically significant. But at the domain of at ease, the pre-value was 3.3, and the post value was 4.0. So it went in the other direction, right? You
Yeah.
felt more at ease, and the p-value there was also 0.03.
Yeah.
So just to give you a comparison between anxiety and at ease, negative, positive, both still statistically significant.
all the numbers and the statistics and everything in the issue 18 of the interior design issue 18 of the Journal of Biophilic Design, where we've published your all the the research and everything. So it is significant findings, and I think it would be really interesting if you could do another one of these. And I don't know if it's possible to use wearables or something, or people got smartwatches to measure their heart rate and stuff, and then you might get that just even people passing by and stuff. Because I know they've been using quite a lot of wearables in some of the research that's being done over here.
Yeah.
Yeah, I wanted to ask you, obviously, you've described emergency departments as like these crazy, chaotic, mad, temporary, purely functional spaces. But this research really should be able to influence and inspire people who are going to be designing or changing or, lobby, if we're going to be lobbying people who are designing or improving these emergency departments. What do you think these places need to look like, in your opinion? If you were going to go, right, I have a magic wand and I'm going to design an emergency cave, to use your words.
Right.
I like that.
Yeah.
I like that.
Yeah.
What do you, in your opinion, what do they need to look like? Obviously, pulling on your own personal kind of feelings. I mean, again, this is, subjective, they're not really
Yeah.
objective, but subjective, but
Yeah.
also now from the objective perspective of the research. What advice would you give? What would you say?
Yeah, no, I think that's a really great question. And I think and what I thought about kind of like the impact of how people's reaction to art, to nature is extremely personal. And so I don't necessarily know if there is like a one size fits all of like all emergency departments should do this.
Correct.
And in particular, in the previous question, it's very hard to study this stuff because it is so subjective. And the great thing about we applied an objective measure, Dr. Gill did a great job of kind of explaining, how by using, t-tests to overcome, a p-value that's less than zero point 0.5, we can show that most of our findings are not due to chance. But as you can see, not every single thing on our measure really responded. Some things are not statistically significant. But, if you go through each individual response, you'll see that for some people, they had a completely positive result to the artwork we showed. But for other people, it didn't. That's the nature of kind of research, is that you try to find a general trend towards if we did this intervention, would we see some positive results? Now, you asked a great question about how, if I could make my ideal emergency room, what would I want? Well, that would be very specific to me. I love nature. I go hiking all the time. I would want to have open windows. I would want to have kind of art rotating through, similar to kind of what I'm doing here. I would have calming music that's playing in the background. I would have kind of a lot more, administrative support. I would have more nurses. I would have so many things. But I think what we can do is, with our paper that we've published here, is that if there's someone out there who is in a research institution or an institution and is looking for some type of ammunition to go to a receptive chairman, and our chairman, Chairman Rohde, he was very receptive to this, especially once we got funding, and say, hey, look, our clinicians are kind of getting burned out with COVID. We are having these many deaths happening. Everyone's gowning up. How can we improve our station? And go into a leadership's office and say, here's some research that shows that I might be able to improve a tiny bit. I don't claim that we're going to fix the burnout process in emergency medicine. We don't claim that. What we do claim is that just a small, simple interaction can make your day and your sense of effective well-being just a little bit better at a statistically significant level. So hopefully that answers your question.
Yeah, absolutely. I think anything that can make an environment better and more comfortable has got to be a good thing. And it's something that's inherent. All the research that's come through our hands and that we publish, and obviously the research that's published elsewhere as well, is the sensory aspects, and that's what biophilic design particularly tries to bring in. It's softening areas, it's making things less reverberating. So most obviously emergency departments, they're very, I'm just going to use the word sort of plastic and metal and reflective surfaces. So it's very noisy anyway. And it's usually like grey floors and very sort of singular colorways that are not
Yeah.
things, because the obviously the biophilia hypothesis is that we evolved in a bio-based environment, and now we are immersed in a man-made environment, which is why
Yeah.
our blood pressures are higher. We get sick, our anxiety is increased. So anything we can do just to reduce that. So views of nature, as even when I took the picture of nature with my mother, again anecdotally, but the doctors and the nurses were coming in and going, "I love coming in this room. I love
Yeah.
coming in here," because it's just they just hung out there for a bit, and it was great for my mum because that had the benefit as well because you could talk to people. Do you know what I mean? So
Yeah.
it's like
Yeah.
there's things that it's, they say it's hard to research, but I think
Yeah, and what I'll add to all of that has been said, and again, agree with all of this, is that to go back to your original question of what would I
yeah,
use as a wand? The answer is that something that you have to incorporate is that each emergency department practice environment is also different in its micro nature, right? The level one trauma center that is Dartmouth-Hitchcock Emergency Medicine, even that compared to NYU level one trauma center is different. Where Anand practices in a community ER practice, that is different, right? But there are these clear givens that we already do in emergency medicine, to give you an insight into it, that is actually not so different from what we've done in the study. Essentially, what this study does is creates a mandatory pause, correct? And says for a minute, look at this, right? But in the practice of emergency medicine, to give you, if we go to the trauma bay, when it comes to pediatric traumas, there's literally a thing called a pediatric pause, right? After a cardiac arrest happens, which is when the heart stops and you do CPR, and any major resuscitation, whether it's a positive outcome or a negative outcome, we do a mandatory, most places do a mandatory debrief where you before you move on, the whole team sits and pauses and looks back. What worked, what didn't work? And to me, I think that same culture of pause and understand the problem before you fix the problem, right? Eh, And biophilia worked for us. Biophilia worked in our department, but we were lucky to have the philanthropy, the departmental buy-in, and things like that. So I would say that if I had my magic wand, I would look to find a tool that speaks to your local microenvironment and its stressors. So first, you have to understand the problem before you fix the problem. And I think our tool, for lack of a shameless plug, is a great tool. But almost every chair and almost every department has to have a tool like this because otherwise it's just eminence and not evidence,
yeah,
right? And so I think what I would love to do in changing the microenvironment and the actual physical space is empower every emergency department to A, have this conversation, B, develop their own specific tool that says, let's do this because this is important. And alongside the way, I would say, if you can have some sunlight and windows, that'd be great.
Yeah. Well, yeah.
absolutely. I can't stress that enough. Exactly.
Mhm.
I mean, I find it really interesting because when you submitted this to me, Dr. Shukla, that it was from your perspective as a healthcare professional. Do you think healthcare systems are beginning to value the workforce well-being more? Are you seeing that over your side of the pond?
Yeah, I think that's a tough question, and I'm, just out of fellowship, like I find that our healthcare system here in the United States can be absolutely exhausting and kind of like, a meat grinder at times.
Yeah.
I think, in places where they do value their workforce, they try to do wellness initiatives and they try to listen to their clinician staff on how we can improve. This is something that they can potentially use as a small adjunct. But the reality is that our healthcare system in the United States is very much broken. We have a variety of different payers. We have different, different types of healthcare systems. We have tough ways to track and, deliver healthcare. I'm in a fortunate situation where I work in the military healthcare system where everyone does have follow-up, but we have our own problems. And, I think that health is so intrinsically, uniquely individualized. And the systems that we have developed to provide healthcare to individuals, it just sometimes it shades over what is the very personal doctor-patient relationship.
Mm.
A lot of doctors want to do the right thing, but some doctors can't do the right thing. And it's because that they have their hands tied. But, I think that initiatives like this and kind of like refocusing towards how can I make my workforce better?
Yeah.
How can I improve the workforce so I can develop a better product? That is really leadership driven, and that there are some institutions that have kind of like strong leadership that can say, my workforce is important to me because I feel that if I have a strong, healthy workforce, well, I develop a better product.
Yeah.
There are other institutions kind of in our country that if they feel that a physician is completely burned out or is not producing they just get rid of them and they replace them with someone else. So it's a tough, there's so many different systems. I'm fortunate in the military system that I have great leadership and, I have a great kind of system where everyone has a primary care. But there are other places that unfortunately don't have that same philosophy. So I'm happy to hear what Dr. Gill has to say.
No, I agree. I think, back in the day when I was a resident, and dinosaurs walked the earth. But I will say that compared to I've been an emergency physician now for 11 years and an intensivist for about 9. Um, I will say that the conversation is moving in the right direction, but there is a tremendous amount yet to be done. I think we were starting to get into a realm where, there are wellness committees, wellness committee chairs. There's not just a departmental, but institutional and macro organizational, like the American Academy of Emergency Physicians, like kind of at a very national level. And I speak at some international conferences as well. And this was a conversation that was happening, and then COVID happened.
Yeah.
Right. And we're now looking at the secondary stress and the moral injury of COVID in a completely different way, right? Because we all know, whether it was in the UK or here, there was a time in COVID where healthcare workers were heroes and then there were zeros, and everything in between, right? So I think the conversation is happening, but there is still undeniably a tremendous amount yet to be done. But I think what's also still a little distressing is that, the solution, like Anand said, is not being customized. The one size does not fit all, and there's this push of like, this works, right? So to go back to your prior thing about how biophilia can play a role, right? Like I would love to actually have a study like this then be discussed with things like leadership, architects, engineers, that why is there a structural reason, an architectural reason why every emergency department is in the dungeon? Come on. Why can't we what happens if you put the next emergency department on the roof?
Yeah.
And probably, the engineers will be like, how do you get the ambulance up there, doctor?
Yeah,
But
exactly. Yeah.
but but the reality is, like, look, come on, there are, that is an extreme example, right? But the solution and the counter to that is they can't all be on the ground either, and they all can't be windowless either. So extreme of anything is bad, right? And we have to learn from our colleagues locally, internationally, and really, I think the next step I would like to take is a more concerted effort at understanding the local micro problem before we just say, okay, here's the, X number of dollars, X number of doctors, and X number of resources that are just blindly being applied or homogeneously being applied to a very, very heterogeneous problem.
Yeah, absolutely. I think just what you're pointing out there, really, that this combination of talking to everybody, having but the conversation I'm having with architects and interior designers, they often get value engineered out. They'll say, oh well, we need to have natural light, or we need to have this particular circadian lighting within it's a normal workplace, just normal office, even let alone where you need that absolute accurate focus and communication as well. Because if places are noisy, you're not going to be able to hear properly. There's going to be miscommunication and all those kind of dangers that could lead from there. But they say if we can get it in stage 1, stage 2, and get all the actors and all the users and everybody on board right at the beginning, I think there's a lot to be said by that. And by what you're saying, both of you really, is to look at the local situation and devise something from there. But actually to talk to you guys when you're actually designing the place. It's kind of,
I mean, it's
how
like
about that
I'll give you a
then?
simple example, because then what ends up happening sometimes is we're playing catch up, right?
Yeah.
So I'll give you this. I keep harping back to this window and daylight thing, right? One of our nurses actually, and I think it was even our medical director, Dr. Jennifer Pope, who brought up this really smart idea that the glass door, the sliding glass
Yeah.
door to your emergency department room. Let's just put like half of the pane, something that reflects. It's just wallpaper that shows morning light, and that you could pull that pane over during the light hours a day, or you have a clock that works in the room, or that the right people are addressing the right things by saying good morning, good afternoon instead of just hello.
Yeah.
Yeah.
Um, and so it's that system. Had that been thought of before the wallpaper needed to come out, you,
Yeah, yeah.
they're
Well,
they're just trying to make the best of the situations, but something can be done and should be done, in my opinion, to make things be done better and, for lack of a better word, right from the start.
yeah, and I just want to piggyback off of that, Harman. Like one of the things that when I started kind of doing the background research for this was that the design of the emergency department comes from a very managerial mindset. It is talking about where people are going to sit, where people are going to work, where the computer's going to sit. The difference in other kind of higher performing organizations, which is kind of what I saw at Meta, I saw at Google, I saw at other kind of very high functioning companies, is that they looked at their work environments not from a managerial standpoint, but of a how can I make this into an environment where my employees can innovate? And it's a
Mhm.
very different mindset. And
Mhm.
unfortunately, physicians who are the workers, who are the people kind of at the front line, well, they are not involved in the process of developing their workplace because their expectation is not to innovate in the ER. Their
Yeah,
expectation is to essentially move people and get them to specialists and kind of resuscitate, keep people alive. And a lot of the people in these higher level organizations, they are the innovators. So when they're thinking, okay, we're going to build a new office in Nashville or we're going to build a new office in DC, well, they remember being the innovator. They remember kind of, hey, what type of workspace helped me? And that plays a big role. And so a lot of kind of goes back to when we how we first started this conversation is I kept asking myself, I was like, why can't we apply this to our clinicians?
Mm.
We have all this artwork for the patients, we have this for our visitors. We have a work, Meta and Google have workspaces that are very easy to look at on the eyes. They're not chaotic. They're very good to kind of get work done. They try to declutter, they try to de-stress. Why can't we use these same principles for emergency medicine physicians in the context of coming out of COVID? So hopefully that kind of rounds out a little bit of kind of like, big picture, I would love for, before the hospital is built, if the hospital CEO as a clinician or EM physician can be like, hey, before you build the ER, let's get some windows. But
but also, Anand, well said. But like, look, I want to go back to something that Ness just said earlier. That they just click back when you were speaking. Like, I've never been to the UK. I don't know anything about emergency departments. And Ness just said, the ERs there are very metallic and very non-biophilic, for lack of a better word, right? Like, and look, like, how did it come to be that you can? I mean, there are nice hospitals, right? I mean, there are nice looking buildings and patient rooms and ICU rooms, operating rooms, but somehow the emergency departments are always, the relatively yucky place to go. And just as a concept, right? Like you're not just for the EM physician, but the consultant. We rely heavily on consultants to come in for litany of reasons, right? Um, people have this innate like, oh, I have to go there,
Yeah.
really?
Yeah.
And that should not be. And clearly that's the way across the pond as well. That should not be. Why?
It is.
Why? There's a conversation that needs to be had now about like, uh, for lack of a better word, putting us at par with even the rest of the hospital microenvironment,
Yeah.
right? And you go to two accountant offices, they don't look the same. But most emergency departments look very similar. And that's a little bizarre.
Exactly. Well, we're getting near the end, and before I ask you the final question, I would love to talk to you about loads of other things, and I mean, hopefully, maybe you might write for us again should you find time. I don't know when, but
That'll be Anand's thing as well. I'm
yeah, it's
kidding. I'm
completely
kidding.
buck past. I saw that. I
Yeah.
saw that,
Yeah,
Harman.
yeah, exactly.
Yeah,
Full circle.
yeah, exactly.
Mhm.
So before I ask you the final question, is there anything you would like to add, or would you like to do, would you like to say something to maybe other physicians or healthcare workers, or even architects and planners and designers, and maybe the guys and the women who own these buildings that are like maybe planning something? What would you say? What would you say to them? Is there anything particular that you would like to say before I ask you the final question?
Go ahead,
Yeah,
Dan.
sure. So I'll go first. Like, I think, it ties in a little bit to kind of what would I do if I had a magic wand? And I think like the solution to solving our healthcare crisis is likely right in front of us. We just haven't found it yet. And we can design buildings, we can look at our people, we can treat our people in ways that is better. And how we integrate nature into potentially helping with that mission is, I think, what the next innovator is going to do, what the next architect is going to do, what the next hospital CEO is going to do. This doesn't take much money, but it just takes the ability to think. I see clinicians as part of my ability to provide a good healthcare product. They're not just a sheep. They're not just meat going through the meat grinder. And how can I optimize this clinician? How can I optimize the workspace of my clinician so that they do the good job, so they can do a good job for the patient? And once that, and I don't know the solution for that. I'm not smart enough to kind of come up with a solution to that, but I'm honored that I was a part of a team that kind of, I think, moved the needle a tiny bit to at least have a conversation where a resident, a young faculty, an older faculty can go to their chairman and say, things aren't going well. I think that we could try something simple like this and see if it makes an impact. So hopefully that answers your question.
Yeah, thank you. Yeah,
Uh,
Harman.
What I'll add to that is just, again, first and foremost, just an acknowledgement to the philanthropic support from the Dorothy Byrne Foundation, um, the chair, and everyone on this team, and all the participants of this study. And then, of course, to the journal and to you, Ness, for taking the time, for giving us this opportunity. We're very proud. Look, it's very evident. We're very proud and passionate about what we've done, and again, spearheaded by the good Dr. Shukla here. But I would say that in sum, it's very very simple. We call our work proudly. We call the people that we work with our work family.
Yeah.
We spend a lot of time there, and I would feel appalled if my house looked dirty. My house did not make me feel comfortable. My house and my family members that I would literally live and die for um, uh, do not feel comfortable. That I cannot provide a nook, a cranny, a way, a mechanism, a schema in which people can feel at ease after going through some terrible things. My kid, when she has a tough day at school, she comes home, right? She comes home and feels at home, feels at ease, feels less anxious, feels less tired. Um, and while we show statistical outcomes in our study, these are outcomes that need to just be a permanent reality of our house. And our house, that is our work house, our work family, needs to do this together, and our voice needs to be heard. And if this can take us a step closer, we're honored.
Lovely. That's great. And thank you for doing the research. I know for a fact, I've told people about this podcast, and the things in there. People are interested in it and they want to know. So I'll put links to the obviously to the journal on there, but I'll also put links to anything that you might want to share with me, to yourselves, if anyone wants to reach out to you, or to a place where you can feel, you can answer any inquiries should anyone from the healthcare or design industry want to reach out to you. So the final question that I ask everybody who comes on the podcast is a completely random one, but I'd be intrigued to hear what you think. If you could paint the world with a magic brush of biophilia, what would it look like?
That's like the hardest question, but I will say, because I've thought about kind of just the impact, in terms of biophilia is such a personal experience. And I would hope that if I could paint the world or make a change in the world, is that the same positive impacts that I've had in interacting with nature, whether on a hike, whether, with these paintings or these photographs, that other people can have that same positive impact. Because I think a lot of people, they're looking for this outlet. And like kind of what I said earlier to a previous question, is like the answer is in front of us. We just got to find it. And, if I could have more people interacting with nature, engaging with nature, I think that we'd see a lot more people, perhaps a little bit, less anxious, more at ease, less gloomy. So, Dr. Gill.
Yeah, I'm a little more simple in my answer. Living in New Hampshire for 7 years, you really get this amazing juxtaposition of, are you a mountain person or are you a water person? And I have nothing against the mountains, but I will say if I had my magic wand, there'd be a lot more water. And I'm a water person. So my brush of biophilia would be, a calm, serene brook, a island in between, a large water body space where, I could live in serenity on that island and go to my happy place, for lack of a better word, and then take the little boat or what have you across to go see my friends on the other side that enjoy mountains. But as Anand said, like different things please different people, and different is truly different, and different's not bad, different's not good. But I think the diversity that our biophilic environment that we all came from, right? As long as that is respected, that's fine. And that's what I would hope to ensure with my magic wand, that there's a unique environment for everyone, so everyone can find their own peace and their own happiness in their own way.
Thank you for listening to the Journal of Biophilic Design podcast.